Hi, my name is Aaron Gerds, and I'm an associate professor of medicine at the Cleveland Clinic Taussig Cancer Institute. I also serve as the medical director for the Case Comprehensive Cancer Center Clinical Research Office. And I've had a vested interest in taking care of patients with myelofibrosis and conducting clinical research to better the care of those patients. In particular, I've had an interest in the development of the treatment of luspatercept, which tries to directly address myelofibrosis-associated anemia. Myelofibrosis-associated anemia is very common. Somewhere in the neighborhood of 40% of patients will be anemic at the time of diagnosis. 60% of patients will become anemic within the first year after diagnosis, and virtually every patient will become anemic at some point in time during the course of their disease. So anemia is a very prevalent issue. Anemia is also prognostic, meaning that anemia predicts for worse outcomes in myelofibrosis. And we do see a dose response curve with that. The worse the anemia, the more severe the anemia is, the worse the survival is for those patients. So, and on top of those points that anemia is prevalent and anemia is predictive, anemia comes with a lot of problems. So it can lead to transfusion dependency, which requires regular transfusions to support the red cell count. Anemia can cause fatigue, tiredness, and achiness. And those are all symptoms that we'd like to reverse in patients with myelofibrosis, as you can imagine. Lastly, the medications that we use to treat myelofibrosis can often cause anemia. JAK inhibitors inhibit the JAK-STAT pathway, which is a key signaling pathway for erythropoietin to stimulate the growth of new red cells. So as you can imagine, a common side effect of JAK inhibitors can be the development of anemia. And the development of anemia via JAK inhibitors can be equally as prognostic as anemia that happens at baseline. So something that's important to reverse. We're looking for agents that we can safely combine with JAK inhibitors to improve that anemia. And we've often used ESAs or erythropoiesis stimulating agents, as well as danazol in that end, combining it with JAK inhibitors to improve anemia, as well as single agent effectiveness of ESAs and danazol in this end. So specifically, we've looked at luspatercept. So luspatercept is a drug that's already FDA approved to treat anemia in myelodysplastic syndromes and in thalassemia. And in myelofibrosis, we conducted a phase 2 trial of 95 patients in different types of myelofibrosis patients. We had patients who were on ruxolitinib, patients who were off ruxolitinib, patients who were transfusion independent, and patients who were transfusion dependent. So you kind of imagine in your mind a 2x2 table or 4 individual cohorts of patients with myelofibrosis and myelofibrosis-associated anemia. And what we saw that using luspatercept, we could get responses in all 4 of these categories. What we also learned from this trial is that anemia is something that's actually incredibly hard to measure. You would think it's simple, just measure hemoglobin levels, right? But it's actually pretty difficult to measure precisely the benefit from a medication like luspatercept or ESAs or danazol for that matter. And so initially in this trial, we have a very, very stringent endpoint of 84 consecutive days with at least 1.5 grams increase from baseline for those patients who are not transfusion dependent. And for those who are transfusion independent, we wanted to completely eliminate the need for any red cell transfusions for 84 consecutive days. And as you can imagine, things can make the counts temporarily go down there are totally unrelated to myelofibrosis or their myelofibrosis treatments. For example, you could have a patient who is having a really nice response with luspatercept, anemia is up 1.5 grams, all of a sudden they get a viral illness and temporarily will lower the red cell count with subsequent recovery. If that happens within the evaluation period, that patient was deemed a non-responder. So we did do secondary endpoints, kind of looking at a more realistic or pragmatic endpoints. So for those who are not transfusion dependent, we looked at an average increase of 1.5 grams over the evaluation period. And for those who are transfusion dependent, at least a 50% reduction in the red cell transfusion burden. So for those patients who are not on ruxolitinib and we're transfusion independent, we saw that 22% of patients had at least 1.5 grams increase on average with the use of luspatercept. Those that were on ruxolitinib and not transfusion dependent, we saw roughly 42%, almost 43% of patients have at least 1.5 grams increase on average with luspatercept. For patients who are transfusion dependent, whether they are on Rux or not on Rux, we saw on average about half the patients have at least a 50% reduction in their transfusion burden from baseline. So that's a big improvement. So say those patients were getting a transfusion every other week, they went down to having a transfusion once a month, for example. So with the stringent endpoints, the primary endpoints, we saw that patients who were on ruxolitinib and transfusion dependent, 26% of patients, so a little over 1 in 4 patients, became strictly transfusion independent, which is a huge number, right? So 1 in 4 patients who were getting regular transfusions then no longer needed transfusions with the addition of luspatercept. So that was the biggest and most consistent response we saw across the study. And that particular cohort of patients was taken forward to the Independence trial. So the Independence study is an ongoing randomized phase 3 trial comparing luspatercept versus placebo in patients who are on a stable dose of ruxolitinib and also transfusion dependent. And we will hope to get those results in the next year or so, really kind of cementing the role of luspatercept in those patients. Nonetheless, we did see responses across the board in all patients with myelofibrosis-associated anemia. So therefore, it has been incorporated into guidelines. For example, the NCCN guidelines now endorse luspatercept as a treatment option for patients with myelofibrosis-associated anemia. Again, we need to develop this concept further. It would be logical to start combining luspatercept, which works towards improving anemia, by working along the SMAD pathway with other drugs that might work along that pathway in a very parallel manner. For example, it would be logical to combine ACVR1 inhibition with luspatercept. They both work in the SMAD pathway, but kind of 2 different parallel tracks, and may even go work in a better manner to improve anemia by freeing iron from the iron stores and then pushing that terminal differentiation of red cell precursors. So more work is to be done on how to manipulate red cell development with drugs like luspatercept to better the outcomes of patients with myelofibrosis-associated anemia.